This is QD Clinic. I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live 2024, the meeting that's all about content that gives you confidence and certainty, and given in a culture that you're going to enjoy. The sort of the feel of the meeting is unlike other meetings with short lectures, a lot of accessibility to both your peers and the speakers. I think you're going to enjoy it. Our case today is about GCA and getting off steroids. So this is a patient I saw a while ago, and so I have a 2-year perspective on this story. She's 73 when she presents, and she presents because for a year she's been having TMJ pain and some occasional right-sided headaches, and it's not until, and the TMJ pain really is, on further questioning, jaw claudication. The more she uses it when she's chewing and whatnot, she gets painful. But anyway, that goes on for not quite a year, but it wasn't until she had a sudden loss of vision and was sent by her primary care to the emergency room that everyone said, aha, this is, giant cell arteritis, temporal arteritis, and they put her on steroids. They got an immediate temporal artery biopsy. The steroids, I think she got 2 days of pulse and then was put on 60 milligrams a day. The biopsy showed classic temporal arteritis with a prominent lymphocytic infiltrate within the adventitia, mononuclear cells throughout and around the blood vessel, but no giant cells were seen. But nonetheless, this was compatible with the diagnosis. She was managed with high-dose steroids, and on getting down to 10 milligrams or less, she would have more symptoms, more jaw symptoms, more headache symptoms, and so she was put on methotrexate. And that was nearly a year and a half ago. And then because she, again, on further steroid reduction, when she would get down to, 10 or 6, all kinds of things would go wrong. Lots of phone calls, lots of complaints, no more visual loss, but jaw pain, headache pain, feeling bad, feeling feverish. This was the scenario. And because of that, she's put on, as you would imagine, tocilizumab for steroid sparing. She does well, and that's where we are now, right? She's on tocilizumab, and she's on 8 milligrams of prednisone. Now, using the retrospectoscope, if we look back at all of her SED rates and CRPs when she's on steroids, they've all been rock solid, bottom, not elevated. She presented when the initial biopsy was done and visual loss with a SED rate of 112. It went down to 40 something, and then after that, it's been single digit SED rates and CRPs doing the same. And the question is, how do you know? How do you know it's not a recurrence? Did she really need steroid-sparing therapy with methotrexate and then later Actemra? My answer is yes, because I know I'm more completely treating the condition, and without those, I'm not going to get her off steroids. And she's 73. She has osteopenia. She's only on calcium and vitamin D. She does not have yet a number or a degree of osteoporosis that would require a more aggressive treatment. But nonetheless, she is hypertensive. She does have hyperlipidemia. She is 73. She got to get off steroids. And I think this is a tough love management situation. These patients are very hard to manage, and I think you need to run these kind of cases by your colleagues and get their input on what they would do. What I do is when, the patient declares from me more than once that I can't wean steroids, they're on steroid sparing. And methotrexate is a good first choice. The IL-6 inhibitor is a great choice. I don't know that you need more than that, and there are other drugs that are being developed, other trials that are going on right now that we may have other options for the future. But you're still going to have this issue of how do I get them off the steroids? One, you got to counsel a patient and coach them up. Say, when I drop your steroids, you're going to feel like crap because your body is used to steroids. It's going to say, where's the juice? And you're going to get symptoms that look like the beginning of this disease. You're going to be achy. You're going to feel lousy. You're not going to be yourself. You're going to get, headaches. You're going to get more fatigue. You're going to feel feverish and nauseated. And again, hard manifestations that I would say tongue claudication, jaw claudication, true signs of cerebral ischemia would be the things I'd worry about. Everything else is steroid withdrawal. So figure out the dose where they start to derail and complain. And in this patient, it's at 10 milligrams. And my regimen is 1 milligram a month. And you spend the first 10 days of the month going between the prior dose and the new dose. So with the 10 milligrams, they spend the first 10 days doing 10 milligrams on Monday, 9 milligrams on Tuesday, 10 milligrams on Wednesday, 9 milligrams on Thursday. You go up, down, up, down, up, down by 1 milligram for 10 days. And you tell them, if you feel no difference between the 10 and the 9, you're good and safe to stay at 9. And then you got to tell them, your body's got to get used to that. You need 2 to 3 weeks of that before we can make another change. And you tell them, when you feel like you're doing good at the 9, now that's your invitation to go to the 8. But you've got to tell them, if you don't get off steroids, you're going to get fat, diabetic, cataracts, strange infections, common infections, weird infections, osteoporosis, fractures, bruising, brittle skin, bleeding, muscle weakness, steroid psychosis. Just go on. Give them the plethora of what will happen on chronic steroids. Higher risk of cardiovascular events, right? Higher risk of infections. Higher risk of, osteoporosis and osteopenia, and then fractures that go with it, and a serious risk of cataracts. Do you want to have cataract surgery at your age? Again, the patient has to be motivated. Their only motivation before you coach them up is feeling good, and steroids, boy, they really make me feel good. They're probably quite uncertain about the drugs that you added to get them off steroids, meaning methotrexate, God forbid they look that up, or the tocilizumab. And again, they're only going to get it when you coach them up onto as to the hazards of steroids. These cases are the hardest cases we manage, are they not? Come to RheumNow.live. We got a whole session on vasculitis. Take care.